Good morning, everyone. It's my pleasure to be asked to speak at your meeting today. I'm just going to give an update on metastatic breast cancer. And I think in that regard, it's always useful to go back to the key facts. When we talk about breast cancer in Ireland right now, we have about 3,100 new cases a year. And in terms of palliation, we have about 710 deaths per year. And in terms of how we discuss it, we still talk according to the histopathological subtypes. So those with hormone-sensitive breast cancer, that's HER2 negative, accounts for about 65% of our breast cancer. Those with HER2 positive breast cancer, about 20%. And then the remaining 15% or so accounted for by the triple negative breast cancer group. And we're going to go through some of the advances we've seen in each of these areas. So this slide you will have seen at previous meetings. It was really the seminal work completed by Trey Sorley and Chuck Peru in California when they proposed a molecular classification of breast cancer. And essentially they said that there was four main breast cancer subgroups, two that were hormone sensitive, known as luminal A and luminal B, and then a group that were triple negative or basal subtype, and this last one being HER2 positive breast cancer. And when they correlated this molecular profiling in databases that have previously been reported, what they saw was reproducibly different outcomes for these patients, with the best occurring within luminal A and the worst occurring in these patients with HER2 positive disease. But of course, we must remember that this was at a time before Herceptin had been developed, which has radically changed the outcomes of patients with that particular group. We are always striving for a personalized therapy approach. And right now, if someone comes in with metastatic breast cancer, we're number one, sending them for germline testing, seeing were they born with something that predisposed them to developing this breast cancer. And of course, that's important because we know it predicts benefit to the PARP inhibitors, a group that we're going to talk about shortly. And then we do molecular profiling on patients' tumours, trying to find tumour mutations that are actionable. And the ones that we know about at the moment are patients whose tumours express PD-L1, may make them more prone to response to immune therapy. The NTRK inhibitor or gene mutation, which will give benefit or predict benefit to the NTRK inhibitors. I test all of my patients with hormone-sensitive disease for the PIK3CA mutation, which is present in about 40% of ER-positive, HER2-negative breast cancer and gives me access to the drug alpelisib. And more recently, we're of course noting that these ESR mutations, which again, we're going to speak about shortly. What about how we're doing? Well, all the data suggests that the outcomes of these patients are doing much better. And of course, you know that yourself. This was two slides from the French group a number of years ago now, who looked at the impact of drugs such as the aromatase inhibitors and taxane versus the older drugs that we had. And what we see is reproducibly better outcomes for patients, particularly in those that have the hormone sensitive subtype. But if we look at the principles of metastatic breast cancer, we know that the relapse is most common in the first 5 years, particularly for patients with triple negative breast cancer and HER2 positive breast cancer. But unfortunately, relapse can occur up to 30 years after diagnosis. And of course, this is the reason why it's so difficult for us to look patients in the eye when they say at 5 years, do I have the all clear, doctor, am I cured? Because we know that there's a drip, drip, drip relapse rate up to 30 years post-diagnosis. It is, however, important that right now, if we develop a secondary site, this still is considered generally incurable, although we know that there is a small and increasing number of long-term survivors. So it is critical to biopsy these first recurrences. But as we've seen with the French group, we know that survival rates are improving. In the past, when I would have given this talk, we'd have talked about a progression-free survival of about 2 to 3 years, or survival rates of 2 to 3 years, with stage 4 breast cancer. Of course, now we see that HER2 positive breast cancer is caught up with hormone sensitive breast cancer, and now median survival is approaching 5 years with both. And triple negative breast cancer, where we talked about survival rates of 1 year to 18 months, now we have a survival rate of about 33 months. And our goal of therapy, if you ask us, in stage 4 disease, is to try and improve survival while attaining adequate quality of life. So what are the factors that predict survival rate from metastatic breast cancer? Well, we know that the longer we are out from our initial therapy to relapse, the better we do. That is also true for patients who have de novo breast cancer. So they've developed, we've never treated them for their primary, but they've presented with stage 4 disease. The number of metastatic sites, or rather the tumor load. So if we have somebody who has bone-only disease, we know that those patients will do much better, but also smaller volume of disease, but visceral metastases is important in terms of predicting how patients will do, and hormone receptor status, as we have indicated before. Do we ever use surgery in stage 4 disease? Well, of course we do. We will often use surgery for isolated local and regional recurrences. So certainly for people who work with me, they will note that we may have liver and bone disease completely under control, and then we get primary progression of our breast cancer. That breast cancer will then be removed. Radiation is reserved for more emergency type situations, such as painful bone metastases, potential spinal cord compression, the possibility of superior vena cava syndrome, or if we have an inoperable local regional recurrence. And systemic disease for everything else. And that's hormonal therapy, chemotherapy, and biological therapy. And that's what we'll be pretty much focusing on today. Metastatic disease, again, what we try to do is use treatment that is the least toxic. So if we've got hormone sensitive disease, we're going to use anti-hormonal therapy. If we have hormone insensitive disease, we're going to use generally one chemotherapy agent plus or minus biological agents, because there's been a lot of progress in this regard. And polychemotherapy for those patients for a visceral crisis. And of course, a lot of us would argue how common visceral crisis is. It is certainly not something that we see very often, and often is allocated to a situation where patients may have multiple liver metastases, but they don't have any dysfunction of their liver, or maybe some pulmonary nodules, and patients or doctors are afraid that they may become potentially more short of breath as a result of their lung involvement. So I suppose I thought it might be helpful to kind of consider the type of cases we see in this setting. And case 1 is a patient with hormone-sensitive metastatic breast cancer, a 60-year-old woman who came through the emergency department with increasing shortness of breath, and her chest X-ray showed she had a right-sided pleural effusion. A pigtail drain was put in, the fluid was sent for CNS and cytology, and adenocarcinoma cells were identified. And when we delved into this lady's history a little bit more, we noted that she had had breast cancer 25 years previous, which had been treated with surgery. So what I would have asked my registrars at this time is, well, look, what's your plan here? And if you knew nothing about her prior treatment, what would you expect? And are you surprised at something like this occurring? So in this setting, we would tend to take an aggressive approach. I would have referred this lady for a VATS pleurodesis because she looked like on CT having low volume disease, particularly when she had that confirmation of cancer cells identified. I would have asked the pathologist to spin down this fluid and then test it for ER and HER2. And if I knew she had breast cancer back in 1996, I would have been highly concerned that this was, again, breast cancer relapse by virtue of the sites of disease that were affected. And number 2, the fact that it was probably hormone sensitive in the past. And we know that these patients can relapse many years on. And this slide represents again, very important work that the EBC-TCG, which is also known as the Oxford Overview, do. And essentially what they have been looking at is the outcomes of patients treated with chemotherapy or anti-hormonal therapy or surgery over a number of decades now. And of course, again, back to that point of being so difficult to tell people they're cured of this disease, we see ongoing relapse in ER-positive, HER2-negative breast cancer beyond 15 years from diagnosis. And the benefits of the anti-hormonal therapies that we see tend to be seen at 15 years, much greater than what we would have seen initially at 5 years when patients were asking us, were they cured? So in summary for this lady, she had a stage 4 breast cancer that had pleural involvement with small pulmonary nodules, and her tumor characteristics were grade 2, invasive ductal carcinoma, ER and PR positive and HER2 negative. And for these patients, top line recommendation at this time is to do endocrine therapy always, unless there's a presence of visceral disease. And I can tell you one thing, I rarely see visceral disease. Chemotherapy is not required for the majority of patients, and this is both from European and American guidelines. And why is that? Well, this schematic diagram will indicate the progression-free survival that we've achieved with a variety of lesions within this subgroup. And here you see the progression-free survival rates of between 6 and 9 months with standard care chemotherapy, and these are our best chemos, capecitabine, taxanes, and anthracycline, will push out progression by about 6 to 9 months. Why do anti-hormonal therapy? Well, this diagram or this picture is of George Bateson, the Glaswegian surgeon, who postulated in 3 women with locally advanced breast cancer that if we remove their hormones or their ovaries, that the deprivation of estrogen would cause their cancers to regress, and that is what happened. But thankfully, we don't have to do that kind of modality anymore because we have pharmaceutical agents that can achieve the same thing. So we can manipulate by decreasing our levels of estrogen, and this is achieved by the aromatase inhibitors. These block the peripheral aromatization of steroid hormones that come from the adrenal glands, and therefore reducing our ligand, our estrogen. We can block the interaction of estrogen with the estrogen receptor using the selective estrogen receptor modulators, tamoxifen. And more recent drugs are the estrogen receptor downregulators, which therefore downregulate the receptor and make it not available for estrogen that may be circulating. And the whole idea behind these drugs is they're much less toxic, and we know that the response rates are very substantial, and it allows us to delay chemotherapy as much as we can. So this is a schematic indication of how these drugs work. As you can see at the top of your screen there, the aromatase inhibitors causing a blocking of your ligand, estrogen, whereas at the lower, the estrogen receptor downregulators targeting the estrogen receptor, and the same for estrogen receptor modulators such as tamoxifen. And more modern aromatase inhibitors are the 3rd generation aromatase inhibitors. And the advantage of these is they don't affect aldosterone and cortisol levels, because in the past, we actually had to give patients steroids when we give these anti-hormonal agents. And again, to look at the kind of response rates that we see with the use of these chemotherapy or anti-hormonal agents, we see clinical benefit rates, so CBR, which takes into consideration 1, reduction in our disease, so the definition of objective response, and in addition to that, stable disease at 6 months. And you can see here that we have clinical benefit rates varying between 60 and 70% with the use of the aromatase inhibitors or fulvestrant, the estrogen receptor downregulator, in first-line setting. So one of our first trials would have asked the question, well, look, is fulvestrant, the estrogen receptor downregulator, better than the use of the aromatase inhibitors? And this was a head-to-head comparison of those injections that you see the patients getting in our day wards that are given into their bottom, compared to the anastrozole, which is a tablet that is taken daily. And essentially what we saw was, in the overall group, there was a 6-month improvement in the use of fulvestrant compared to the aromatase inhibitor in the first-line setting. But this benefit was truly seen in these patients who had no visceral disease. So these patients who we see with bone-only disease who do extremely well. And we see there a median progression-free survival of 22.3 months versus 13.8 months in favor of those patients who received the fulvestrant in combination or rather than anastrozole. So as we plot this out, we now see that we're up to 22 months progression-free survival benefit using an injection rather than using chemotherapy, which gave us 6 to 9 months. The landscape for this particular type of breast cancer then has changed radically over the last 3 years, and we've been really lucky to be involved as Irish investigators and patients in this movement. And what we're going to do is talk about many of those achievements that we have done. I suppose the big one is we recognize what the mechanisms of resistance are. Number 1, the presence of an ESR mutation. So this is a mutation in the ligand binding domain of the estrogen receptor. Checkpoint regulation, very important, and we're going to talk about the CDK inhibitors, and then the impact of PI3 kinase and mTOR signaling in terms of resistance. We start then with the presence of an ESR mutation. This is mutations that occur in the gene encoding the estrogen receptor. Now, they are rare in primary breast cancer, it's probably seen in about 2 to 4%, but we see them in up to 40% of patients who have developed metastatic breast cancer. And they tend to cluster in the sequence encoding the 3 amino acids in the ligand binding domain of the estrogen receptor. And the result of this is that we have an active estrogen receptor independent of the ligand estrogen. So therefore, if you imagine, if I have an ESR1 mutation, wouldn't it make sense that I downregulate the receptor, so try and get that to downregulate, rather than using an aromatase inhibitor that's going to take away the ligand? But this, when we have an ESR1 mutation, this receptor is active independent of whether we've ligand or not. So therefore, whether we block the ligand or not doesn't make any sense. So it would make sense in that regard that maybe these patients may do better with the fulvestrant injection rather than the presence of taking a tablet. And essentially, there is some evidence to suggest that the case. So this was the phase 3 SOPHIA study, which looked at Faslodex or fulvestrant compared with the aromatase inhibitor exemestane. And essentially what we saw was that if you had no ESR1 mutation, there was really no difference whether you got one drug versus the other. However, if you did have this mutation, there was a benefit to getting the fulvestrant compared with the aromatase inhibitor. The second mechanism of action is then, of course, targeting CDK4/6. And we know that estrogen receptor positive breast cancer is highly dependent on cyclin D, and cyclin D associates with CDK4/6, which causes progression of the cell cycle from G1 to S. If we inhibit the CDK4/6, we essentially cause a blocking of cell cycle arrest, or rather we cause cell cycle arrest, so our cell cycle does not progress from G1 phase to S phase. And essentially, we get increased sensitivity to our anti-hormonal therapy and increased cell death. And we have 3 aromatase or CDK inhibitors now, which have all been approved in the metastatic setting, abemaciclib through the MONARCH studies, palbociclib through the PALOMA studies, and ribociclib through the Mona Lisa trials. Essentially, what we have seen with whichever CDK4/6 we use in combination with anti-hormonal therapy, we see a 10-month improvement in the initial phase 1 trials in favor of the CDK inhibitor in combination with anti-hormonal therapy. And when we went into our phase 3 trials to prove our proof of concepts that we had seen in phase 2, we see reproducibly at least a 10-month progression-free survival benefit with the CDK inhibitors compared with anti-hormonal therapy alone. So this is now the most advanced in terms of first-line therapy in ER-positive breast cancer. And of course, with the expense of these drugs, we're always trying to identify who are the ones who truly benefit and who don't. And the difficulty is independent of age, the disease, where it was distributed, bone, visceral, etc. We know that all patients benefit from CDK inhibitors. And right now, the current recommendation is if you have somebody with ER-positive, HER2-negative breast cancer, we will give them either fulvestrant in combination with a CDK inhibitor or an aromatase inhibitor in combination with a CDK inhibitor. So really it is, as we see schematically here again, phenomenal response compared to the best chemotherapy agents we have in this setting. Now, Aileen O'Mara is going to be talking about the toxicity of these drugs. So for the sake of time, I will not be going into that. But I suppose what I want to give you an overview, that there are many similarities between the adverse events associated with these drugs. Particularly, we need to watch our patients for neutropenia, and they will attend at various times to get their white cell counts checked. Ribociclib requires cardiac evaluation in addition to liver function tests being checked. And abemaciclib, we see much less neutropenia associated with that drug, but diarrhea tends to be the rate limiting factor. And we will need to watch creatinine levels and liver function tests while on that drug combination. So she goes on a CDK inhibitor in combination with anastrozole and has resolution of most of her disease and does really well for 3 years. And then she develops chest wall nodules and new bone lesions, but she's still in great form. So the question is, where do we go from here? And this is the most pertinent question we have at the moment. We don't really know. Should we continue anti-hormonal therapy? Are these patients still hormone sensitive? Should we change to chemotherapy? We have a lot of questions asked. What is the activity beyond the progression on CDK4/6? We're going to talk about the mTOR inhibitors. Perhaps these should be added into our CDK4/6 inhibitors. And also, do we have biomarkers for resistance to CDK4/6? We know that PI3 kinase and mTOR signaling is a mechanism of significant resistance to anti-hormonal therapy in the setting of ER-positive, HER2-negative cell lines. And PI3 kinase mutations are identified in about 40% of patients with ER-positive, HER2-negative breast cancer. Now, the likelihood of a PI3 kinase mutation seems to be fairly standard in both the primary and advanced disease, maybe slightly higher in advanced disease. So, this SOLAR-1 trial looked at PI3 kinase inhibitor in combination with anti-hormonal therapy. Now, mind, the patients that went into this had not received CDK inhibition in the main. So the vast majority of them hadn't, but they were randomized to receive alpelisib, which is the PIK3CA mutation, in combination with fulvestrant versus fulvestrant alone, and stratified according to whether they had a PIK3CA mutation or not. And essentially what we found was, in the overall patient population, no difference. But for those who were PIK3CA mutant, a substantial difference, 11.1 months versus 3.7 months with the addition of alpelisib. So for me, I'm checking all of my patients in this setting for PIK3CA mutation. And if they have access to that, we now have a compassionate access program, which gives us access to alpelisib in combination with anti-hormonal therapy. And more recent data that had looked at this has a recent trial that was presented out in San Antonio has suggested benefit in patients who progressed on CDK4/6 inhibition. So perhaps the addition of a PI3 kinase inhibitor to this group may again be able to reverse the resistance that we're seeing. I just wanted to give you this slide because it is looking at gene sequencing of patients with ER-positive, HER2-negative metastatic breast cancer. And as you'll see, the arrows are indicating the higher levels of mutation identified. When I am testing my patients, particularly with the Oncomine analysis that is completed in St. James's, I'm particularly looking for ERB2 mutations, the likelihood. So here we see in this slide 7%. It's usually about 2 to 4% in the general population, but higher in those patients with lobular carcinoma, the presence of AKT mutations, and again, seeing 40% of patients with PIK3CA mutations. So again, these are the kind of things we're looking for because we need new targets for this patient group. Our second case and our second subtype then is HER2 positive breast cancer. And this, my case, is a 58-year-old lady who presented in 2008 with the left breast lump and had a mastectomy and axillary clearance for a very high volume node positive breast cancer, was HER2 positive. And my registrar has asked me, well, what does HER2 positive mean? Well, we know that HER2 positive breast cancer is seen in about 17 to 20% of breast cancers. The seminal work was done by a man called Dennis Lehman over in California when he completed Western blots looking at gene amplification within a number of breast cancers and noted that in over 100 women, about 30% of them so had amplification of this HER2 oncogene, which translated into HER2 oncoprotein overexpression. And when he looked at the expression of HER2 in these patients and correlated with outcomes, he noticed that those patients who were HER2 overexpressed did far worse. And this culminated in a huge amount of work, again, looking at cell lines, adding in HER2 blockade, adding in chemotherapy, noting that these patients did better, and the genetic engineering of a HER2 blocker, now known, of course, as Herceptin. It was a monoclonal antibody, which has led to substantial improvements in the outcomes of patients. So my lady has a CT scan done 5 years after her diagnosis of her primary, and she's got lung and liver metastases. And we ask our juniors, well, what kind of options are you thinking about? Well, we know that the pivotal phase 3 trials looking at Trastuzumab, the Herceptin molecule in combination with chemotherapy versus chemotherapy alone, demonstrated a survival benefit in patients with HER2 positive metastatic breast cancer and led to the approval of this combination for patients with first line treatment in HER2 positive breast cancer. The positive what we've seen with the use of Herceptin in metastatic disease is, like what we would have indicated at the start, that the outcomes of patients have improved substantially. And while you saw in the trial, the slide that we looked at initially, that the molecular classification showed that the HER2 positive breast cancers did the worst, we now know that those patients who had HER2 positive breast cancers as metastatic, that were treated with Protusomab, had exactly the same outcomes as those patients who had ER positive, HER2 negative breast cancer. And this was a massive change at that time. But of course, we've moved on from that and we're doing even better again. The landscape of HER2 positive breast cancer is now a very crowded site. After Herceptin occurred and was approved in 2001 in combination with chemotherapy, we then had in 2013 the approval of Protusomab in stage 4 disease. And this was the Cleopatra study, which looked at two HER2 blocking agents, Protusomab, which blocks the interaction of HER2 with HER3, and Trastuzumab, which blocks the interaction of HER2 and HER2. And essentially, what has occurred is you're blocking the potent homodimerization and heterodimerization with a block on downstream signaling pathways. So as you see on the right of this slide, you see much less activity and increased cell death with the use of these two monoclonal antibodies in combination with chemotherapy. And that chemotherapy agent was Taxotere. And in the first analysis, we had a 6-month improvement in progression-free survival reported with Protusomab added to Trastuzumab. More importantly, with more recent final overall analysis, we see at a median follow-up of 50 months that there was a 15.7-month improvement in survival for patients who had received Protusomab in combination with chemotherapy and Herceptin versus chemo alone with Herceptin. More recent drugs are called these antibody drug conjugates. These you're going to be hearing a lot more about. What you can see from the schema here, on the right-hand side of the slide, you see your Herceptin molecule, then you have a bridge linker to your payload, which is your chemotherapy drug, and in TDM1, this is Intanzine, which is a microtubule inhibitor. And essentially, this is a very exciting technology where your receptor binds to your Herceptin-like molecule, you then, or your monoclonal antibody binds to your receptor, you then get internalization by endocytosis and delivery of your chemotherapy agent specifically to your cell, thus preventing toxicity to our normal cells. And the addition of TDM1, which was combined at that time to standard care chemotherapy, Lapatinib in combination with capecitabine, showed a 3-month improvement in outcomes, which again pushed TDM1 as second line once patients have progressed on chemotherapy in combination with Herceptin and Protusomab. The big challenge, however, for HER2 positive disease is the fact that a significant proportion develop brain mets. So between 1/3 and half will develop brain metastases over their time with metastatic HER2 positive disease. And we know from the Affinity trial, which looked at patients in the curative setting, 2% of these patients who had low-risk cancers came back with brain metastases, despite the fact they had no liver disease, no lung disease, no bone disease. So we need to improve the outcomes of these patients. And this trial that was recently reported in the New England Journal was the HER2 CLIMB study. And it was looking at the drug Tucatinib, which is a small molecule HER2 blocker in combination with Herceptin and capecitabine, which would be standard, let's say, 2nd or 3rd line chemotherapy, compared with the same chemotherapy with Herceptin. And essentially what we saw was that at 2 years, the survival rate for those patients who were on the Tucatinib arm was 45% versus 27%, and a median survival in excess of 4 months better with the use of Tucatinib. And more importantly, what we saw was the actual progression, because they allowed patients with brain mets to come into this study. What we saw was that there was reduced the risk of progression or death by half in patients with had brain metastases. So this Tucatinib will start again escalating the chain, going up into earlier lines of therapy to reduce the incidence of brain metastases development. One exciting drug, and we're hoping to open this trial shortly in St. Vincent's Hospital, is using Trastuzumab deruxtecan, which is a novel, again, antibody drug conjugate, which is looking at improving outcomes for patients with HER2 positive metastatic breast cancer. This drug is, again, a monoclonal antibody that it has a linker to a topoisomerase 1 inhibitor. And what we see is in heavily pretreated patients who'd received Herceptin, T-DM1, Protusomab, our best drugs, the response rate, as you can see in this waterfall plot, 61%, incredible. And we've not yet received an overall survival number in this phase 2 trial, but we need to watch these patients for interstitial lung disease because they get leaking of the payload, which is causing a bystander effect, and therefore we need to understand that a little more. So as we finish for HER2 positive disease, we see that taxane in combination with trastuzumab and pertuzumab is first line. Second line is currently T-DM1, but that is likely to be challenged in the coming months as that last drug we talked about, trastuzumab deruxtecan, escalates the chain. We'll then move on briefly to triple negative breast cancer, which is defined as what it isn't: ER positive, PR positive, or sorry, ER negative, PR negative, HER2 negative breast cancer, first documented in the medical literature in 2005 and noted by the fact that it has a higher rate of relapse, particularly when it comes back. It's in year 2 to year 3. The survival rates of these patients was previously reported as 12 to 18 months. Now it is looked at about 33 months, but when the disease comes back, much more likely to affect the viscera and highly associated with incidence of brain metastases. There have been multiple molecular classifications proposed for triple negative breast cancer, and what we see is that it is a real mixed bag, with patients who are probably very sensitive to immune checkpoint inhibitors, patients who may have a much slower growing triple negative breast cancer that may benefit from androgen receptor blockers, and other drugs such as the SERC inhibitors may be beneficial in the mesenchymal subtype. But it has been generally treated with single agent chemotherapy to date, with the consideration of the use of platinum salt chemotherapy in those BRCA mutation carriers. And really, if we're going to make any progress here, we need next generational sequencing. The immune checkpoint inhibitors using immunotherapy is escalating in a lot of different cancer types. This is particularly noted in triple negative breast cancer. We know that the response rates still aren't as great as we'd love them to be, less than 20%. But the rationale for using immune therapy in triple negative is because they tend to have more immune infiltration, so tumor infiltrating lymphocytes, and we see higher levels of PD-L1 on both our tumor cells and our immune cells, and greater numbers of non-synonymous mutations leading to tumor-specific neoantigens that activate neoantigen-specific T cells. We have a fairly good idea who should be treated with immune therapy so far, insofar as the ones that tend to do best are those patients who are in first line that have PD-L1 positive disease. And this has been looked at in the recent phase 3 trial, the Impassion 130, which was in the New England Journal, which looked at atezolizumab in combination with the chemo drug nab-paclitaxel compared to nab-paclitaxel alone. And essentially what we saw was in the PD-L1 positive group, this was where we had an improvement in outcome, a 38% improvement in progression-free survival, which led to this being accelerated approval by the Food and Drug Authority over in the States. And that is held with ongoing follow-up. The BRCA mutated patients, we see them in about 5 to 10% of our breast cancer. They benefit from our PARP inhibitors. As you will be aware, patients who are BRCA1 and 2 mutated have deficient homologous recombination, which is double-strand DNA repair. They rely on the PARP pathway to repair by single-strand DNA repair. So if we knock out our ability to repair by single-strand, we're essentially getting an accumulation of DNA breaks, which should increase the likelihood of apoptosis. And we have two PARP inhibitors, talazoparib and olaparib, which are two oral drugs, which both have demonstrated improvements in progression-free survival compared to standard care chemotherapy. And for patients who harbour these BRCA mutations, we will use these drugs compared to single agent chemo. Chemotherapy for those patients who don't harbour a mutation is fairly standard. As you can see, there's a pile of drugs. Many of them don't have great response rates, and we're trying to do a trial and error model to try and make these patients improve. But one drug that is definitely coming to the fore is sacituzumab govitecan, which again is an antibody drug conjugate. The antibody is targeted at TROP2, which is expressed in many epithelial cancers, particularly triple neg in about 88% of them. And the payload is SN38, which is a high drug to antibody ratio of about 8:1. And essentially it is a prodrug for irinotecan, but thankfully does not have the type of diarrhea that we see related to irinotecan. And we had seen from earlier trials that the response rate in heavily pretreated patients was about 30% or so. So we really wanted to know, in the phase 3 trial, was it better than many of the other drugs that we use? And the ASCENT trial has just reported out recently, comparing sacituzumab IV with standard care chemotherapy. And again, we had this trial halted for futility because the sacituzumab was so much better, a 59% improvement in progression-free survival in favour of this drug, with a 6-month improvement in overall survival. So we're watching this space. So as we come to the end of this talk, if my patient is triple negative and PD-L1 positive, I will use atezolizumab in combination with nab-paclitaxel. And if they're PD-L1 negative, I'm always considering them for clinical trials. But if they have a PARP, a BRCA mutation, then I'm thinking about PARP inhibition and certainly wanting to get my hands on sacituzumab govitecan. I want to just end then with skeletal related events, which of course are a substantial burden of disease and many things you're dealing with in the palliative care clinic. We know that they have direct consequences for our patients in terms of pain, potential impact on mobility, and lead to lower mood, lower quality of life, and obviously have a significant impact on our healthcare system. And we know in breast cancer that particularly with stage 4 disease, it's a common site of metastasis. So the likelihood of skeletal related events will be 68% in patients who have prior bone lesions. And what we're essentially getting is an imbalance of osteoblastosis and the osteolytic process. And we know for patients who develop skeletal related events, they do worse, with median survival 16 months in those patients who have not received a skeletal related event versus 7 months in those that have. So we have a number of drugs that we have been using, bisphosphonates, which of course are embedding in the bone and induce apoptosis of activated osteoclasts, and then denosumab, which binds the rank ligand inhibitor and basically blocks osteoclast differentiation, so preventing bone breakdown. And these drugs have been looked at head-to-head in metastatic breast cancer. And essentially what we see is a slightly greater ability to delay the time to first onset of skeletal related event with denosumab compared with zoledronic acid, and obviously the benefit being that these are subcutaneous drugs that be given in the community. But as you'll be aware, we will give a combination of zoledronic acid in the day ward versus denosumab on the basis of what that patient situation is. If someone's receiving treatment in the day ward, very often they will just get their drug intravenous as part of that treatment. So this is a real whistle stop of the progress that has been achieved with metastatic breast cancer. I hope it's been helpful, and I hope you have a great day. Thank you.